We've got some time for some questions and discussion with Peter. So who would like to ask that first question?
Good morning, folks. Peter, thank you. Very, very powerful presentation and stories. I'm Bob Henderson. I'm on the board at the Health Quality Safety Commission, and I am a pilot. My great concern and my great fear when I walk around inside the healthcare system is not the attitudes of the people in the system. It's the resources, it's the things they have to work with. So let's just assume these Mentos are a vial of drugs, and it terrifies me when I stand in an operating theatre and I see drugs that do different things, that can help and that can harm, and they have the same colour for the label, the same size font for the label, and yet some of them are lethal. And that's just a small example of the sorts of issues I see. None of you would allow me to fly you around in an airplane if Boeing and Airbus did completely different things with their aircraft. But that's what is happening within the hospitals that I see. So I'd appreciate your thoughts on how we might address that problem.
So great question. Because of time constraints, I didn't go into the third dysfunctional story about we think safety relies on the heroism of our clinicians rather than the design of safe systems. And let me give you, so I would love to talk further on this. We have been negligent as leaders in pushing that agenda. Let me give you some example. We, like you in Australia, have built these magnificent new hospitals. The outsides look like artwork. The insides look no different than they would 60 years ago. We buy devices that don't talk to each other. We set our systems up for mistakes. We bought these electronic medical records, and our staff, our doctors and nurses, spend 60% of their time documenting. Our nurses spend 15% of their time manually double-checking pain medicines or any medicine when it's both in two electronic systems. And I'd love to push with you on this, because the way we buy health service, or the way we buy technology or procure technology, would be the equivalent of this. And I love how you're a pilot. Let's say Boeing is building a plane, and as you know, they might subcontract to about 1,000 different vendors. I'm seeing if I can show you a video that explains this. And imagine now the vendor that makes the landing gear says to Boeing, you know, Boeing, I don't want to send a signal to that cockpit for the pilot to see if the landing gear is up or down. That's my data. You can't have it. Pilot's going to have to guess, right? What would Boeing say? Goodbye, not buying you. We'll get another. It wouldn't even be a discussion. And yet we, as leaders, buy medical equipment every day that the vendors say, it is my data. And the worst culprits are the EMRs that we spent money on, or the device manufacturers, and they don't allow us to talk. And we accept that. We say, oh, no, that's okay, landing gear maker. It's your data. You don't want to do it. Planes will crash. People will die. It's real expensive. But don't worry about it, right? And I think, especially you as New Zealand, we have to start demanding and procuring much better and stop buying these clunky and clumsy systems, because it's only us who are paying for it who are going to be able to do it. I'll give you another example. We grossly overspend for building healthcare technology. It's now about $2 million for a bed in the ICU. And part of the reason why it's so expensive is every monitor has alarms built into it, right? So they all want their own proprietary software, and all of them are in an alarms race to make their alarm most annoying, regardless of which one's most important, right? The least annoying alarm gets the most attention. Our nurses we studied answer a false alarm every 90 seconds, right? It's absolutely absurd. How does it work on a cockpit? Well, every sensor doesn't have its own alarms. That would be ridiculous. There's a central alarm that coordinates them, that prioritizes them, and it's much safer, it's much more effective, but we haven't begun to purchase that way, and so I think we need to do it. Are we going to be able to show it? I want to show you a video of something we're working on. It may be something we explore together to build the first integrated hospital. So sorry for that little digression, but you could it's a pet peeve of mine. But one of the reasons why I'm so excited about this is we need to get our healthcare costs down. And in every industry, there's only two ways you do that. You use fewer services or you grow productivity. It's not magic. Globally, the only thing we're talking about is using fewer services. And there are some services that are clearly harmful, and there are some services that are the result from harm. But most of our health care services have some marginal value. The question is it worth it? Is that CAT scan that, I think it's a 2% chance it's a tumor. I'm not really sure, but you can go without that CAT scan, right? You're going to say, no way, I want to know it's not a tumor. But we don't deny services in every other industry. What we do in every other industry is grow productivity. And our engineers, in walking through our health delivery system, think we can get 40 to 50% productivity gains because it's so designed, like, absurdly poor. I mean, all those inefficiencies. There's an economic modeling that says if healthcare would just get 4% productivity gains, we'd solve our healthcare cost problems. So I think you're spot on. And one of the things we're working on, I'd be happy to share with you, is I'm leading an effort for the Institute of Medicine. It's the scientific body in the U.S. Now it's called the National Academies of Medicine, to guide hospitals on how to procure better. So I'm literally getting the Boeings and the submarine people who did this in their industry and making a toolkit for hospital execs to say, don't buy things if they don't have open APIs and they don't talk, or you're wasting your money. So love to follow up more on that in the future. Another question.
Thanks, Peter. David Grayson. I'm a surgeon here in Auckland. Nice to see you down here finally.
Yes.
I'm just interested in, Johns Hopkins is obviously a great teaching institution as well, and we're recognising that we need to actually change the curriculum for our medical students in nursing and allied health. In our New Zealand Medical Journal today, a study just released about medical students practising on themselves because they have no other way they think to do it. So could you tell me how much influence you are having from a safety and quality perspective in influencing a change in the curriculum at Johns Hopkins?
Yeah, David, great. It's great to see you, and fan of all the great work that you do. We've done a number of ways, and David, the reality is our medical education is just as siloed as a hospital. So there's the people who control the curriculum, and many of them are basic scientists who were literally refusing to give up any time for non-basic science curriculum because they thought you wouldn't get it in. But we've navigated it. So what do we have? We have a curriculum that we've published for our second-year medical students. That's the basics. It's almost that same certificate that the middle tier gets on human factors, on lean, on patient-centered care. And then in each of our core rotations for medical students, we've built on that targeting. So, for example, in surgery, we focus on teamwork and lean processes. On OB, we talk about critical incidents, so like the hemorrhaging mom, and begin to build it out. Where we found we still had gaps, although literally just month we did it, was in our residency training programs, because every program director has their own person who leads it, and some of them, were quite independent. They wanted to do their own thing. The last leap that we just made that we're excited about is listing all the harms. And again, we list some generic ones, but every department adds to it. But they say you need to have a residency program that makes sure you're competent in these harm-based skills, and we're beginning to do that. We have some training with doctors and nurses and pharmacists in that medical school curriculum. So the safety course that we offer second year, the nurses are invited to it too. We try to have a joint course, but the calendars didn't line up. I mean, it went up to our university president, and the deans didn't want to, their calendars were fixed, but at least we're able to invite the nurses to attend the medical. And I think you're absolutely right. I'd love to hear what you guys are doing down here to address that, because it's a big issue to make sure we produce people who could live this way.
Questions, Margaret?
Thank you very much, Peter. My name is Margaret Wilshire. I'm a CMO here at one of the Auckland hospitals. I've got one cheeky suggestion and one question for you. And my cheeky suggestion is, why not use the lung as your example of a fractal structure? Because unlike the tree The lung has pores of cone and it has redundancy in its circulation with collaterals. So that's analogous to the example you gave of clinical communities, because it's the cross-fertilisation at that very low level. And so as an intensivist, which I think you are, if I remember correctly from a previous talk, it's a great metaphor for you, but you can ignore it. And
it's so funny you say, well,
This
it's
is
funny
the
you say,
Kiwi
I
way.
don't have, I have a video explaining what's a fractal, but you're absolutely right, lungs
Lungs are fractal
glomeruli are
structures.
fractal,
Yeah.
our capillaries are fractal,
Yeah.
so maybe, but you're absolutely right,
Yeah.
they're elegant structures that connect us in ways that allow you to get really important work done, so thank you.
But they have the collaterals. The question I have relates to harm well down the line after the patient has left hospital. You talked about harm in our hospitals, but I suggest to you that a lot of harm actually isn't realised until well after the 30-day mortality marker that we measure. It might be 1 year or 2 years. When we take a frail older person into the operating room and we do things because we can, just like we can put a man on the moon, that might not be great for that person either. And it certainly won't be good on Mars. But if we do things to those people, then their mortality rate at 2 years is very high, and yet we don't reflect on that. So I want to ask you about value in that context.
Yeah, so great question, and simply because of time, I gave you some examples. So this communities that I said we break down, we have a harm review committee that has our home care company, our primary care company, and our hospital people, and our palliative care looking at that exact question. So we do a number of things to find the learning opportunities. We review deaths in the hospital, or deaths really anytime, but we also look at what we found was that our home care nurses had great insights of things that were, as you were saying, these kind of complications, but we had no structure for them to feed that back into our primary care docs or into our hospitalists or other docs. And so we now begin to have that structure. We do that, we have an insurance company that serves around 350,000 employees. And so we coordinate with that, but that's an area where we need to go further. It was also an area where we had no structures for the conversations, right? And so now we at least have some of those structures, but we need to even fractalize that, so that's happening in every primary care clinic, right? We have it so the chief quality officer for our home care company, for our primary care company, for our hospitals, and then myself coordinate that discussion, but that cluster has to cascade down into different communities. So great point.
Other questions? Ken?
Good morning, Peter. My name's Ken Clark. I'm another Chief Medical Officer, a Medical Director of a DHB further south in New Zealand. I need your advice, and I see in our system, in our evolution, in terms of the systems that we have, that we're at a point where we're building accountabilities and we're building reporting lines. They're there, but to some extent in New Zealand at the moment, the emperor's got no clothes. And by that I mean, I was struck that you said that a key responsibility at any point is is resourcing of the next point.
Right.
Resourcing of the next point. And that's my take-home message
Exactly
today.
Right.
I need some advice on how we make that happen, how we move that. We all know there's no more resource. It's how can we divert resource and make the case for diversion of resource in a meaningful way at every level, whether that's the board to the executive team, whether it's my role to my clinical directors, whatever.
Right.
How can we really make that jump? Because the accountabilities and the reporting is coming and it's there, but the resourcing isn't. And in New Zealand we have a great phrase of the number 8 wire culture, or doing things on a shoestring. Well, quality's still on a shoestring in this country. Yeah,
so great point. And I think you're right. The traditional accountability is blaming and shaming, right? Rather than supporting, it's whipping or really holding someone. That conversation was really key because it forces the leaders at every level to prioritize. So if we say we're focusing on harm, and you say, okay, well, this is a harm, then you have to manage your own resources. We didn't inject a lot of new resources, but it really forced people to say, what could I stop doing, or how could I align resources? Or for the leader to say, you know, I just can't perform on that measure, right? I mean, because a lot of this is driven by external regulators. And, but the vast majority of what we did was simply breaking down silos that were inefficient, that were all doing their own thing but weren't aligned. The other piece, Ken, that we really focused on is to make sure we're mindful of total cost of care and not some small budget. You know, let me give you an example, and I'm almost embarrassing for this. We had some examples of sternal wound infections in our cardiac surgery or other ones, and part of what, to get them down, we wanted to use wireless EKG pads, you know, because the pads stick. But we spent literally, when I heard about it, it was going on for about 8 or 9 months, whose budget those pads were going to be on, because it wasn't, as you said, I mean, it wasn't a new expense, and the nurses said, I don't want it on my budget, the anesthetist said, I don't want it on my budget, the cardiac surgeon, and they were literally fighting over, nobody debated if it was the right thing to do, but it was just stupid. We didn't have a mechanism, so finally I said, okay, this is absurd, you know, I'll absorb it, or went to our finance guy and said, we need a way to solve these problems, because we do a lot of that myopic of whose budget it is, but everyone agreed these infections are really expensive, and there's probably 20 examples of that where we have to break the silos and say what the total cost of care is. We just did a study in our system where, as you know, decubitus ulcers are really expensive, and our health system cut our wound nursing budgets thinking that it was going to save money. And what did we show? We showed that nurse staffing for that is a U-shaped, that you get to some point where you cut your resources and it now becomes a cost, and your total costs go up because the incidence of events goes up. But most of our leaders think of nurse budgets or quality budget just as linear, right? That I can cut more and more and more, and there's no tail to that curve where you say, no, you've cut to the bone and you start to go up, and total cost goes up. So that is kind of where the journey we're on. But what it forces you when you have these structures is to have that conversation of how could we pool resources. But it's not easy, and it's why we spend a lot of our efforts, as I know you do, in helping people, what we call do change leadership. Because that technical part of this is probably easy, right? I mean, like the EKG pads wasn't hard. The hard part is getting people to all agree together and give up something they have and work with others. And that's something I think we could do more leadership development in, you know, as a field, because God knows I learned this by making mistakes over years, and I sure wish we had more of a leadership development program for our junior doctors and nurses.
I'd like to ask Anthony Hill a question. So Anthony is our Health and Disability Commissioner, and of the people in this room would see more complaints and required to undertake investigation of complaints or incidents within the New Zealand health system. And I guess my question, Anthony, would be keen to hear some of your insights, but in particular where the lack of clinical community peer support and review has resulted in the sort of incidents that come across your desk in particular.
Thanks, Steve, and fabulous presentation. Thanks so much. Just music, really. Could listen all day to the kind of things that you're talking about. Was expecting to be asking questions rather than answering them, but very happy to make some comments. I was really struck by your conversation about clinicians and the way they relate to one another and the connections, and again, all of that, themes with which we are familiar and, frankly, delivery with which we struggle. In the serious cases that I see, so I get to investigate, essentially call them medical error cases for the purpose of this, there is, without exception, in every senior serious case with which I deal, the concept that someone in the room knew. And if you think of the room as the systems, the machines that don't talk to one another, the information that isn't communicated, the question that isn't asked, the doctor who doesn't listen. It's there every time, but every time. And we see that in the surgeon who simply doesn't know that the patient is a Jehovah's Witness and has denied blood products, but the anaesthetist does, but didn't think it was worth mentioning to the guy holding the scalpel. We see it in the deteriorating patient and the nurse who knows that tragedy is 10 minutes away, correct, but isn't heard when the doctor speaks. So I guess your comments about culture and about communities that connect and respect echo profoundly here as they do in other human communities, and I'd strongly support, and I'm really interested in catching up on some of your most recent literature around your third wave and the direction of travel around that. But I guess I'd be really interested in your comments on how do you untangle that?
Correct.
And it's not just about the cultural dimension of that checklist. How do you have a community, a team that's wrapped around a patient and equip them to genuinely communicate so that when someone in the room knows, when we have everything that we need to properly treat the patient, we reliably and sustainably do it. In New Zealand, we're pretty good at it, but the fact is our margins are fatter than they need to be where these things go wrong.
Right. Boy, great question. One, just before I address that, because I forgot to do this, these clinical communities, we're also doing them for patients with chronic disease. And they are magical so that they, we took this idea, so just like Weight Watchers or AA, we now have COPD, depression, peers supporting each other. But as you, to get back to your point, we are kindred spirits. We looked at our sentinel events and our liability claims, and 90% of them, somebody knew something was wrong and either didn't speak up or spoke up and wasn't listened to, right? And that's that resiliency part of high reliability is underdeveloped. I'll share with you at least the journey that we're on to address this. We had a doctor who was filming women on GYN exams for 7-8 years and didn't get caught for a while. And so our board said, why didn't somebody speak up about this, Peter? How is it possible? And to find that, we engaged in a study where we conducted anonymous interviews of staff. Literally no one at Johns Hopkins knew. We had one of my colleagues from the UK, Mary Dixon Woods, did this, and asked what are the barriers to speaking up and speaking out. And we use this framework of speaking out is peer-to-peer, which is the most effective and should happen more. Speaking up, going up the chain of command, and then obviously whistleblowing is kind of the top, which is really a failure of those lower levels. And one of the main things we found was that our organization had people who were, quote, untouchables. That these were people, largely surgeons, but not only, who brought in a lot of money, had a lot of power, and staff were afraid to ever question them because if they did, they thought they would be sanctioned and or nothing would happen. They would just be putting themselves at risk. And we had that research presentation publicly presented to all our staff. It was really quite risky for us, but we said if we're going to change the culture, we have to get this out into the open. And one of the people in the audience sent the dean and myself a letter afterwards and said, you want me to speak out? Here's a department chair in our organization. They're quite powerful, I suspect, like here, who has been an untouchable for many, many years, and nobody's done anything about it. You've known about it. What are you going to do? And obviously the question is, okay, what do we get ourselves into? And he said, no, we can't blink now. This is our moral moment of truth because your culture is defined by the worst behavior you tolerate. Right? It's a really key concept. If we allow that to happen as leaders, that's how we're defining our culture. So we use the mechanism that we use to investigate scientific misconduct to just borrow them to say we're going to investigate professional misconduct. Right? It'll be fair, it's independent, but they're going to go in and talk to your peers and they're going to say we're here because we've had concerns about your behavior, and they're going to make a report, a recommendation of either you could be coached or trained, or no, this has been going on so long it's not flexible. And since we've done that, it has been transformative. We've removed now about 7 people from positions of power. Now, some of it where this has been going on for a long time and we just had a backlog. We haven't been as responsible for this. Many we coach, we have a hotline in our organization to allow anyone to anonymously submit concerns about these speaking up behaviors. And we had to simplify it because what we found is that we had behavior or ways to report sexual harassment, HR, compliance issues, but it required that staff would know even what counts as that type of behavior. And the reality is we didn't train enough people. So now we said, you just have to know it's something you don't want to have going on. Just submit it and we'll triage it once we get it in to say, okay, who does this map to? Does it go to HR? Does it go to legal? Does it, whoever it goes to? The other thing we did as part of that was train leaders on how to create a culture where people speak up and speak out. And for example, there's a great book called Humble Inquiry by Edgar Schein that says, to get a culture of people speaking up, don't blame the workers. It's leaders' job to do that. And they could create it by doing 2 simple things. By having relational talk rather than just task talk. So I get to know you. Hey, Tony, so what's going on? How was your weekend? How are your kids? Because as I know you, you're much more likely to say, Peter, did you know this happened? And then also asking humble questions about, hey, what do you think's going on? And having the senior clinicians role model that, whether that's in the operating room, just like a pilot would in the cockpit to say, hey, keep me safe. I'm worried about this. And then finally, training people when they hear news to create psychological safety. But really what it boils down to is responding actively and constructively. What do we mean by that? Actively means, oh, please tell me more. Constructively, okay, I want to hear about this. Hey, we're going to do something about it together, rather than saying, oh, don't bring me this bad news. I don't want to hear about that. It's going to open a can of worms. And finally, the last capacity building piece we had to do, and we're in the midst of it now, was to train our department and division directors and nurse managers on how to have difficult conversations. Because what we often found was that even when people brought these up, those more local leaders weren't comfortable in having these conversations, and they just swept it under the rug. They said, he just had a bad day or she had a bad day, and they weren't doing it. So we put together this multifaceted approach to try to do it. If the number of issues that get surfaced is a marker of success, and I don't know that it is, we've had great success. The final piece that we've done now to create this culture is linking these cusp teams in ways that reflect patient flows. What do I mean by that? If you look at mapping patient flows, and Justin, obviously you have a whole tool and technology that does that, there are certain highways through hospitals that they can go, right? Whether it's, in our case, the surgical or oncology program to surgical onc, OR to recovery room to certain floors to some post-acute surgical care. We had handoff issues along all of those, but we had no structure to resolve them. So what we would do is complain, right? The ICU people would say, well, if those floor nurses would only did what I tell them to do, it would solve our problem. Or if those home care people would only do what I told them to, but we had no way to bring them together. And now we've linked those cusp leaders in all those highways to say, stop complaining about each other, get to know each other and figure it out, and so that we build structure. So I don't have an answer, but I think it's the missing piece of, if you buy this resiliency program, yes, we need to standardize, but lean and standardization is not going to solve this problem, right? This is a human problem, a cultural problem, and I think it warrants much more attention than it has in the past.
Thanks, Peter. Look, we've got time for one last question. Following this question, we are going to break, and Janice, I think we're to have a photo. Is that the, I understand, Jess,
Sure.
Is that the plan?
Yes.
Okay. So one last question for Peter before we bring this to an end.
Thank you, and thank you for being so inspiring. I'm Rosaline Robertson. I'm the Chief of Clinical Governance for the Southern Cross network of private surgical elective hospitals in New Zealand, and I won't make this lengthy, but do you have some wisdom to share, please, around the I will create a governance system like a finance one?
Yeah, I sure do. So what I would encourage you, so you have several hospitals, it sounds like. What I would start at the board and literally say, could I map down to the bedside, anywhere you deliver care, who's that responsible person for quality? What structure do they have to meet with payers? So the higher level structure, do they have that meeting where a hospital might meet with the various department directors? And what measures do they share, right? I mean, and literally you could walk down that cascade of thinking about that. And then in that ask, is there any part of your care delivery that the measures don't go anywhere? And I suspect the answer will be yes. I mean, like I mentioned ped surgery. We also found, for example, GI endoscopy. I mean, really risky thing, but for whatever reason, they didn't report their measures into medicine, I guess because they thought they were proceduralists. They didn't report it into surgery. So I think just starting that and asking, who's the point person? Do they have a structure that gets all those lower levels to report? And then each of those lower levels you have to cascade down. And it'll take you, once you do that, a year, 2 years to build that. But then you have the scaffolding to truly be high reliable. So thank you.
Thank you. Okay, Peter, look, we're going to need to bring the session to an end because we need to get you to Canterbury this afternoon. And so on behalf of EY and on behalf of the New Zealand, or this New Zealand meeting, thanks so much for your time this morning. Thanks so much for your words of inspiration and the work that you do. On behalf of EY, we look forward to working with you within Oceania and bringing some of those lessons and learnings to New Zealand. This is a wonderful opportunity, and we thank Johns Hopkins. Thank you, Nancy, for support. Aloha. Thank you for coming all the way from the US to support this wonderful initiative.
Just as an aside, one of the reasons why we've partnered with EY is to help develop tools to address your exact question. Like, okay, it's great you have theories. Now, how do I put this life-saving stuff into practice? And so that's one of the things we've been working on with our colleagues of how do you literally develop the toolkits that allow you to walk through that to make it easier so that we could be visible. So thank you all for coming here and traveling, many of you, and hosting me in your most beautiful country. And I hope I'm back soon.
We'll make sure of that.